Chapter 2, Alveolar Gas Exchange. Alright, this is a pretty short chapter, but that doesn't mean it's an unimportant chapter. This is gas exchange. This is an important component when we think about the respiratory system. First thing we have to do is just remind ourselves of some basic ideas of gas and pressures. So, pressure of a gas, the partial pressure of a gas. So P here stands for partial pressure of the gas, is equal to the fractional concentration of that gas times atmosphere. So if we go down to the bottom, if I look at ambient dry air, PO2, partial pressure of oxygen, oxygen's about 21% of atmospheric air. So the PO2 of dry ambient air would be 0.21, 21%, times total pressure at sea level, that's 760. So the partial pressure of oxygen is 160 in dry ambient air. I emphasized on the previous slide that was dry ambient air to bring home the idea that, remember, when we breathe air in, it is humidified to 100% humidity and warmed to 37 degrees. Now, it is humidified to 100% humidity, so we have to take into account water vapor pressure. And the partial pressure of water at 37 degrees C, and the air is 37 degrees C because we warmed it to that, is 47. Which means we must take into account water vapor pressure when we want to talk about inspired PO2. Because we've added in a gas without changing the total pressure, that means the partial pressure of the other gases is going to change. So the partial pressure of an inspired gas, taking into account water vapor pressure, is we just take the fractional concentration of the gas times atmospheric pressure minus water vapor pressure. In other words, minus 47. Example, inspired PO2 would be 21% of atmospheric air times 760 atmospheric pressure minus water vapor pressure gives us 150. So dry ambient air, the partial pressure of oxygen is 160. But inspired PO2 is 150 because we humidify it to 100% humidity. And that is a very important consideration. All right, let's examine what happens with respect to diffusion. We just calculated inspired PO2. Okay, that's 150. So the inspired PO2 is 150. However, by the time we get down to the alveoli, notice that the partial pressure of oxygen is dropped to 100. A couple of reasons for that. Number one, it's diluted by CO2. We have another gas in there. And always remember that oxygen is continuously being taken up. To the left, as I've boxed and highlighted, are our partial pressures of venous blood, low oxygen, high CO2. So the PO2 is about 40, PCO2 is about 47. So we have a pressure gradient for oxygen to diffuse in and a pressure gradient for CO2 to diffuse out. Gases are going to move. They're going to diffuse based upon pressure gradients. Notice by the time we get to the end of the capillary, the PO2 has equilibrated with the alveolus. It's now 100. We went from 40 to 100. And the CO2 has now equilibrated with the alveolus. We went from 47 to 40. Since both gases equilibrate, the term we use for that is perfusion limited. So if a gas is perfusion limited, this means in the blood we equilibrate with what's in the alveolus. So there is no longer a partial pressure gradient by the time we get to the end of the capillaries. So in that time available for diffusion, the gas equilibrates. That is referred to as perfusion limited. Next, as we go around, we see systemic arterial gases. So this would be an ABG. Let's look first at CO2. Notice that CO2 is 40. Once again, I want to re-emphasize the following point. In tidal PCO2, which we mentioned before, in tidal PCO2 is alveolar CO2. And notice that that's also arterial PCO2. So in tidal is alveolar is arterial. In the normal lung, they're all the same. So that's why we monitor in tidal CO2, because it's giving us arterial CO2 under normal circumstances. But notice that the oxygen has dropped a little. We went from 100 to 95. We haven't passed through a capillary bed. We just went pulmonary veins, left atrium, left ventricle, out into the aorta, systemic arteries. So we haven't gotten to a capillary yet. So where did that oxygen go? What happened? Well, this is referred to as the AA gradient. Capital A for alveolar, small a for arterial. And it's normal to have a difference, a lower arterial than alveolar. This is because primarily of anatomic shunts. Remember your anatomy, there are some shunts, okay? These are right to left shunts, venous blood mixing in with arterial blood, pleural veins, bronchial veins, the Bayesian veins. So that small amount of shunt blood flow is reducing the oxygen. It's not enough to change the CO2, but it does reduce the oxygen. Again, this is called the AA gradient. And this will be an important diagnostic tool and thing to think about when we get to diagnosing the hypoxemias. All right, what are our factors that are going to affect our main alveolar gases? We'll start first with alveolar PCO2. Two factors. Alveolar CO2 is directly related to CO2 production and inversely related to alveolar ventilation. So CO2 directly related to CO2 production. And if we stop and think about that for a second, hopefully that makes good sense. Alveolar CO2 will be directly related to the production of CO2, but it's going to be inversely related to alveolar ventilation. The greater the alveolar ventilation, the lower the CO2. And again, hopefully that makes sense, because it's the lungs' job to blow off, get rid of CO2. The greater the ventilation, the more I'm blowing it off. At rest, CO2 production is pretty much constant. And so changes in alveolar CO2 can help evaluate alveolar ventilation. I also want to point out that alveolar CO2 is arterial, and arterial CO2 is a tightly regulated variable. We must regulate CO2 very, very tightly. And the reason for that is because CO2 is an acid. In short, it behaves like an acid. It generates hydrogen ion. So it's going to be tightly regulated. So if we think about this, let's say CO2 production is no longer constant. Let's say CO2 production goes up. What must happen to alveolar ventilation to keep CO2 constant? If you said alveolar ventilation has to go up, you're absolutely right. It has to go up. So if CO2 production goes up, alveolar ventilation is going to go up in concert with it, proportional to it, to keep CO2 constant. Two big ones to look for on step one: increasing CO2 production, hyperthermia, and exercise. We all know when we exercise, we breathe more. Well, that's to try to keep CO2 constant. So if CO2 production goes up, alveolar ventilation goes up. If CO2 production goes down, say when you sleep, alveolar ventilation goes down to keep CO2 constant. CO2 is a very tightly regulated variable. Now, the alveolar air equation gives us the factors that are going to influence alveolar PO2. All right? Yep, you need to know this equation, even for calculation purposes. The alveolar air equation, very important equation to know. But it also tells us the factors influencing alveolar PO2, and we have to utilize this in the diagnosis of hypoxemias. So, as you can see from the relationship, 3 factors affect alveolar PO2. Number 1, directly related to atmospheric pressure, 760 millimeters of mercury at sea level. However, as we ascend and go up in altitude, atmospheric pressure falls, therefore I know alveolar PO2 is going to fall. So we can go the other way. If we increase atmospheric pressure, say hyperbaric conditions, or go for a dive, we'll increase alveolar PO2. Second factor is fractional concentration of inspired oxygen. For room air, that's 21%. For room air, that's 21%. But if I increase the FiO2, fractional concentration of inspired oxygen, then that's going to increase alveolar PO2. And hopefully that makes sense. You put someone on supplemental oxygen, the goal is to increase alveolar oxygen and ultimately arterial blood oxygenation. So hopefully that one makes good sense. Third factor is CO2. Normal is around 40, but notice alveolar PO2 is inversely related to alveolar CO2. We are subtracting the CO2. So if we increase alveolar CO2, we're going to decrease alveolar PO2. And if we decrease alveolar CO2, we will increase alveolar PO2. Let's think about that for a second. If we increase alveolar CO2, how would that occur? Most likely condition to increase alveolar CO2 is to hypoventilate. Well, if I reduce ventilation, I'm going to reduce oxygen, right? Hopefully that makes sense because you're breathing in the oxygen. Now, if alveolar CO2 is low, then you're overventilating. In general, that's going to be the main thing. So I'm breathing too much, and if I increase ventilation, I increase alveolar PO2. So hopefully that makes good sense. Last part of the alveolar air equation is RQ. RQ is the amount or the moles of CO2 produced for the amount of oxygen consumed. Normal level is 0.8. All right, so let's put forth an example. Person breathing room air at sea level. So that's 760 millimeters of mercury minus 47, that's 713, times fractional concentration of oxygen, 0.21, minus the normal CO2 of 40 divided by 0.8. If you calculate all that out, you get 100 millimeters of mercury. Why do we use for a textbook alveolar PO2 100? Because if we use normal numbers, the alveolar air equation says it's going to be 100. Hopefully that makes good sense for you. We'll talk about diagnoses of hypoxemias later, but don't forget the alveolar air equation because we're going to utilize that in our diagnosis. All right, now let's talk about the actual transfer of gas across the alveolar membrane. This is going to follow Fick's law of diffusion. We had a Fick in the cardiovascular. It's the same Fick, but that was Fick's principle related to oxygen consumption, blood flow, and extraction. This one's a little bit different. This is Fick's law of diffusion. The alveolar compartment and pulmonary capillary blood compartment are going to exchange gas via diffusion, and it will follow Fick's law of diffusion, which states that the rate of gas transfer is equal to the area divided by the thickness times the diffusion constant times the pressure gradient. All right, so let's think about things that are going to be important for step 1 that will relate to Fick's law of diffusion. There will be 2 structural factors and 2 gas factors. All right, let's talk about some structural features that will affect the rate of diffusion. First is surface area. Remember, diffusion directly related to surface area. If surface area goes down, then diffusion goes down. If it goes up, then diffusion goes up. 2 big ones for the step exam here will be emphysema, there's a decrease in surface area, thus a decrease in diffusion. In exercise, we increase the surface area, and thus there will be an increase in diffusion. Next factor is the thickness of the membrane. And again, this is the membrane, or the total aspect related to separating the alveolar gas from the capillary blood. If the thickness goes up, then diffusion goes down, and this increases in fibrosis and the other restrictive diseases like sarcoidosis, asbestosis, silicosis. So these structural problems in the lung, pathology-wise for step 1, include loss of surface area, emphysema, and an increase in thickness of the membrane, restrictive diseases. You could also throw in pulmonary edema. The results of all of this are this will decrease diffusion of oxygen and carbon dioxide. Second factor influencing diffusion directly related is our diffusion constant. Hey, this is mathematics. We have to have a constant in there. Okay? The diffusion of the gas is dependent upon how soluble it is. The more soluble, the faster it diffuses. The only real thing to relate this to for step 1 is the following. CO2 is very soluble. Oxygen's pretty darn soluble, but not as soluble as CO2. CO2 is much more soluble, thus it diffuses faster across the alveolar membrane than oxygen. So let's think, in that previous slide, the pathology. If I have a problem with diffusion, which gas will be affected first, oxygen or carbon dioxide? Okay, if you said oxygen, excellent job. CO2 diffuses faster, so it will be more resistant to alterations in diffusion. And when I have a patient who has a problem with diffusion, you will see that in oxygen before you see it in CO2. The final factor influencing the rate of diffusion is the pressure gradient. And hopefully this makes sense. I mean, if you have a bigger concentration gradient of a solute, you have a greater rate of diffusion. Well, the same properties here. The greater the partial pressure difference, the greater the rate of diffusion. Oxygen has a 60 millimeter of mercury pressure gradient because alveolar is about 100, venous is about 40. And that's what we talked about on one of the first slides in this section. If I increase this gradient, then I will increase the rate of diffusion. How do we increase the gradient? Well, we administer supplemental oxygen. By administering supplemental oxygen, it will help the diffusion of oxygen. Of course, it's not going to enhance the ability to remove CO2, but it will increase the diffusion of oxygen. The goal would be to return the rate of oxygen diffusion toward normal. The gradient for CO2 is only 7, so we have a 60 millimeter mercury gradient for oxygen, but only 7 for CO2. So clearly the gradient for CO2 is less than that for oxygen. However, CO2 still diffuses more rapidly. Why? Man, is that CO2 soluble. It is much more soluble than oxygen. So even though I have less of a pressure gradient driving CO2, it still diffuses faster because it is so soluble. All right, now let's talk about the idea of diffusing capacity of the lung, DLCO. DLCO. Now, one of the things we mentioned earlier was the idea that if a gas equilibrates, it's perfusion limited. So that's one of our terms to describe the overall dynamics of transfer of an individual gas between the interstitium and the capillary. So oxygen, CO2 under normal circumstances equilibrate, so they are referred to as perfusion limited. And what this term means is it takes into account Fick, but it also takes into account time available. All right, Fick defines the basic factors that influence diffusion. But we have to remember the blood is always moving through the alveolar capillary. So there's only a certain amount of time available for that diffusion. So if it equilibrates, then it is perfusion limited. If it does not equilibrate in that time frame, it is diffusion limited. Now, creating a diffusion limited state could relate to time available in the capillary or the ability of the gas to diffuse across. Or it could be influenced by what happens to the gas in the blood. But bottom line, if it doesn't equilibrate, it is diffusion limited. But even though most of the time, if it doesn't equilibrate, it's diffusion limited, you shouldn't assume that it doesn't diffuse well. You could just have inadequate time in the capillary, or something could be happening with respect to it in the blood. And that's where carbon monoxide comes in, and that's why I bring that up. Carbon monoxide doesn't equilibrate. All right, it moves across the capillary or the thickness of the barrier very, very well, but it still doesn't equilibrate. Because it doesn't equilibrate, it is a diffusion limited gas. And we take advantage of this clinically because if we measure carbon monoxide uptake, it gives us an idea of the overall diffusing capacity of the lung. And we'll look at that on the next slide, this idea. Okay, here's a picture showing that we have just a little bit of carbon monoxide in the alveolus, say about 1 millimeter of mercury. And in the blood leaving, the partial pressure in the plasma is so low that we can just pretty much ignore it. It says on the slide that it's 0. Well, technically it's not 0, but it's darn close. It's darn close. So notice, alveolar is 1. In the blood, in the plasma, it's 0. So carbon monoxide has not equilibrated. It is a diffusion limited gas. Now, the reason we use carbon monoxide is because of this property. It is diffusion limited. In order to determine, and I won't go into all the mathematics of this or the technical aspects, in order to determine the uptake here, we must be able to measure this venous level right at the end of the capillary, the partial pressure of the gas. Well, we can't do that in a patient or a volunteer even. No one's going to volunteer for you to figure out a way to sample blood coming right out of an alveolar capillary. So since it doesn't equilibrate and since it's so low, we can just ignore it. Now, the reason it doesn't equilibrate is because once it starts moving into that plasma, it quickly jumps onto the hemoglobin molecule. And so that's why in the time available for diffusion, it doesn't equilibrate. Okay? This uptake of carbon monoxide is your clinical measure of the overall diffusion of gases in the lung. So we use we know carbon monoxide is dangerous, but we use just a little, and therefore we can calculate carbon monoxide uptake, and we know that it will be proportional to the area over the thickness. Fick's law of diffusion. So again, your clinical marker of diffusing properties of the respiratory system. This picture is not in your book, but I bring it in because it's a very high yield pictorial representation of perfusion limited versus diffusion limited. All right, let me try to set this up. From left to right, we have time in the capillary. So there's only a certain period of time that the blood is in the capillary. So just imagine you have a chunk of blood going through the capillary in this time frame. On the left will be the partial pressures in the blood. Notice that curve A starts at a certain partial pressure. Curve B doesn't start. It starts at 0 partial pressure. Now, both of these are gases, A and B. And what's at the top, the dashed line, represents the alveolar partial pressure of that gas. All right, notice the blue line, A. In the time available in the capillary for diffusion, notice that the blood partial pressure of gas A equilibrates with the alveolus. So you see the blue line go up to the dashed line alveolar and then flattens out because now it is equilibrated. Can't go above because this is simple diffusion. So gas A equilibrated with the alveolar gas Thus, it is perfusion limited. Curve B, notice, doesn't even get close to the alveolar partial pressure of gas B. Because it doesn't get close, because it doesn't equilibrate, it's diffusion limited. Now, maybe you've already figured this out, but the prototype for A is oxygen. So that's diffusion characteristics, time in the capillary for oxygen. B, classic example there, is carbon monoxide. So I show you this graph because you may see something like this. They may assess you on this idea on step 1. Again, A, oxygen, perfusion limited because it equilibrated. B, carbon monoxide, not even close to equilibrating. It is diffusion limited, and that is carbon monoxide. That is our prototypical diffusion limited gas.